Swayam Prabha. Digital India. Educated India.
Welcome friends once again to our NPTEL MOOC module on health economics. We have been discussing so far on theory and principles of economic evaluation. This is our second part of the understanding of principles of economic evaluation. What we did in the last lecture is all about introducing its principles. We also clarified about full and partial economic evaluation and types of full economic evaluation, and also we decided which type of evaluation we should choose. And in this lecture we are trying to understand the further details of the least and most performed full economic evaluation. Among the 5 methods which we discussed, the least performed one are CCA and CMA, but other out of other 3 which we said mostly used, but among those mostly used, the CBA, that is cost benefit analysis, is usually targeted and performed. So, as a snapshot of the previous lecture, once again just to recap for your knowledge and for better understanding, let's understand once again what are the types. We discussed these 5 categories, and out of that we highlighted first 3 and next 2, and we said this is most performed and the least performed, and why the last 2 principles of economic evaluations are not usually performed. The simple answer to this is that the assumptions which it has taken, these are actually based on the assumption of 2 evaluation principles that make it hard for the evaluator to compare the alternatives. That is one of the biggest problem of the CMA and CCA approach. Now, out of the CMA and CCA, this can be understood from the differences in the basic assumptions discussed in the last lecture as well. In terms of their cost, output or consequences, and by their formula, you can just see these 2 methods, CMA and CCA, it has a problem in terms of cost and output. Especially in CMA method, you will find so far as output is concerned, this is usually identical in all aspects. However, this is very rarely found. When we check with CCA, that is cost consequences analysis, the set of cost and their output, that is set of consequences, are really hard to choose and compare. That is why CMA and CCA is less used. But knowing how it is actually carried out is very important. In terms of definition regarding CMA, that is cost minimization analysis, it is a form of comparative economic analysis where the cost of 2 or more policy alternatives, which are all assumed to have equivalent health effects, as mentioned by Turner et al. In 2021 study. The objective of this study is to minimize cost given the output which is similar in all aspects, or this is similar in all aspect. That is why we said identical in all respect related to the outcome is indeed very rare. There are limitations of this method that in this case generally this is not recommended because it ignores the fact that healthcare has a heterogeneity of outcome. For more detailed discussion, you can refer to the paper by Briggs and O'Brien in 2001. Example of CMA is also mentioned. Let us again take the hypothetical example of recent COVID-19 crisis where we witnessed India-based vaccine by Bharat Biotech is the company who introduced the intranasal vaccine that is named as Incovac, and another one is Covaxin, and that is indeed pre-existing injection based vaccine. India's first indigenous COVID-19 vaccine. We also discussed this earlier in the previous lecture. Now, in this case, what are the problems? To determine which treatment option minimizes the cost while having the same output, that is curbing the the spread of COVID-19. So, in this way the government the purpose since was to minimize the cost, the approach was to allocate the health budget and generally the allocation is considered to fixed and allocation was made with a target of efficiency. So it is important. So, we are just comparing once again Incovac and Covaxin. We mentioned that the cost per patient in the case of Incovac was 200 rupees, whereas the output was for COVID prevention, and another treatment is called Covaxin, which was the India's indigenous vaccine. The cost per patient was 150, which was lesser. Output was with the same. Now, let us assume India aims to vaccinate a population of 90 crore. Okay. So, the total cost for the treatment A, that is for Incovac, is a number of patients times the per unit cost, that is 200. So, 200 times 90 crore is of course 18,000 crores. Okay, 9 into 2, 18. So, 18,000 crore is as per the treatment A, whereas for the treatment B it will be of 150 times 90. So, it will be rupees 13,500 crore. Now, we are just we can just see from this example that the total cost of treatment A is higher, but we will just check. So, this is what is mentioned. Since both treatments are equally effective, that means controlling or to prevent COVID-19, both the Indian government will choose treatment B because of its cost, because of its budget. So, it is the most cost effective option as of lower cost, and the decision ensures saving of rupees 4,500 crore. That is the difference between the treatment B and treatment A. Although we use this example to explain CMA, however, the scenarios with identical health output or effectiveness are really rare, since we started with assumption that the output is identical. Okay. So, now we can answer in other scenario as well. In which of the following two scenarios CMA would be used? Okay. So, you can just have a check once again what we just said. We are trying to say cost minimization analysis and we are explaining these two CCA, that is cost consequence analysis and cost minimization analysis. So, out of these two you will just find out from the example which we are just citing in front of you. In scenario 1, we are just taking that imagine two brands for an identical generic drug, one package in a standard bottle that is cost 20, and so CS is the cost 20 per unit, and the other in an eco-friendly container, and then the cost is actually 30. So, the active ingredient and the effectiveness of both drugs are the same. That is one consequence of the outcome is identical, as I just said. In the other scenario, imagine two brands of an identical generic drug, one package in a standard bottle rupees 20, and the CF, that the eco-friendly container, the cost is even lesser than that of the previous one. So 20, and the active ingredient and the effectiveness of both drugs are in this case are different. So, you can just see out of these options where CMA would be most useful. So, it is indeed you just check on your own, and with our answers which we explained a couple of minutes back. So, this is where we try to mention the scenario 1. So, what is then the CCA? Once again, another least performed full economic evaluation principle. The last two principles we have said. In fact, it is a form of comparative economic analysis that evaluates two or more policy alternatives in terms of their relative cost and outcomes. In other words, or in the words of Drummond and others, 2005, cost consequences analysis, that is CCA, is a form of economic evaluations where disaggregated cost and a range of outcomes are presented to allow readers to form their own opinion on relevance and relative importance to their decision making context. So, CMA, where the identical outcome is considered, here in this case outcomes, not multiple outcomes of interest are reported, and CCA does not have a specific mathematical expression like the evaluation principles. If so, then how the evaluation is carried out. So, we will just explain this once again. For the CCA, show results for different costs and effects separately. So, each decision maker can choose which cost and effects are most relevant to their local content and viewpoint. CCA should capture as many relevant costs and impacts of the intervention as practically possible, and list in a tabulated form by cost and their outcome. By cost, it might be cost of intervention, cost of primary and secondary units, then cost of informal care, then social care, etc., productivity and other cost. In terms of outcome, so the effects are noted, the broader health effects such as safety, adverse events, well-being, and even non-health effects such as user experience, satisfaction, empowerment, social inclusion. On patient effects such as health system efficiency, caregiver outcomes are also noted. We will just try to understand this through another example. Here we are taking the two cases, that is a healthcare decision involving two different treatment options for managing a particular medical condition such as hypertension, where the blood pressure is measured. Usually high blood pressure is counted. So, one intervention is through blood pressure drugs for the high blood pressure, a commonly used drug for hypertension, and second one is called the lifestyle modifications, in short LSM, like such as exercise, diet improvement, yoga, etc. In two intervention, we can compare their associated cost and their consequences. It is indeed important to note that you are not looking for a single summary measure like other evaluation principle, but rather providing a detailed account of this cost and various outcomes associated with each intervention. So, these include the following, like the associated interventions, intervention 1 and intervention 2 in terms of cost and the output. So, in terms of cost, for the intervention 1 may be medication cost, maybe physicians visits, maybe laboratory test, maybe any potential side effect, and whereas in intervention 2 for the lifestyle modifications or lifestyle improvements or measures, we can have cost for their lifestyle counseling, dietitians, exercise programs, potential adverse effects, etc. In terms of output, we can check for the intervention 2, that is lifestyle improvement, we can check their improve BP, patient satisfaction, quality of life, and the same quality of life can also be checked in the first intervention where the cost for drugs is counted, and usually in the first case, that is since drugs is taken, so systolic BP reduction is counted, and similarly diastolic blood pressure can also be checked. So, a CCA table might look like this. You can just see their cost, their systolic blood pressure readings, then maybe diastolic BP reduction, then patient satisfaction in a scale of 1 to 10, etc. This kind of figure might be available or researcher might collect. Here the healthcare decision makers can use this information to make informed choices based on their specific priorities. Like if reducing cost is a priority, they might lean towards lifestyle modifications, or BP drug would be preferred otherwise based on cost. CCA allows decision makers to consider a range of factors beyond a single metric, making it a viable or a valuable tool for complex healthcare decisions. Another example you are just citing to check the cost for the another intervention, that is, suppose a healthcare facility needs to choose between two different COVID-19 testing methods. The facility here is to compare the financial and non-financial consequence of these testing methods. So, like there are two alternatives, one is for PCR testing and maybe rapid antigen testing. So, the total cost is maybe in both the cases are 30,000 or 50,000. Accuracy of result, turnaround time, resource utilizations, and patient discomfort, you can just check in both the way. Hence, this particular table provides a clear overview of the cost and various non-financial consequences associated with each testing method. So, decision makers use this information to trade off between cost and consequences. The final decision depends on relative importance of these criteria for in terms of the facilities, goals and priorities. Use of CCA. CCA have been recommended for complex interventions that have multiple effects. For example, lifestyle education in diabetes as mentioned by Drummond and Sculfer et al. 2005. CCA may also be particularly useful in feasibility or pilot studies when it is not clear which cost and outcomes will be most relevant to future definitive trials, and given the limited funding available for this feasibility study and the scarcity of health outcomes, so or the scarcity of health economists, especially the feasibility and its scarcity, CCA can provide a less resource intensive alternative. So, there are disadvantages and advantages of CCA. So, you can just go through in terms of disadvantages. There are no specific and definitive guidance. It has a limited generalizability. Then in terms of interpretation also, it is more subjective, whereas the advantages are like it's easy to understand and apply, and this presents a broader range of health and non-health cost alternative approaches to measuring cost and outcomes as part of CCA. Advantages are counted. So far we discussed least perform full economic evaluation principle, and that is CMA and CCA. We begin discussing the main economic evaluation tools, that is CBA, CA and CUA, starting with the cost benefit analysis, then we will follow other two. Even the welfare perspective will also be counted while understanding the analysis. The discussion about main economic evaluation principle starts with a very basic approach that is called CBA. So, this is a form of comparative economic analysis that evaluates two or more alternative terms of their relative cost and outcomes where both cost and outcomes are expressed in monetary terms, that is were highlighted and also mentioned in Turner's et al. Paper. In simple term, the CBA counts all costs and benefits whatever they are, and then whoever incurs them, and these are weighed against each other, especially in monetary terms. And the specific objective of CBA is to maximize achievements of decision making goals and to identify Pareto improvements or potential Pareto improvements. So, the features of CBA, that is as I already said, the monetary evaluation of both cost and effects, similar to CCA. So, CBA includes non-health benefits as well along with health benefits. CBA enables evaluations of any interventions of health project or studies that improves the quality and convenience of particular health service. CBA, when only formally evaluates cost and consequences of a single policy option and do not appropriately account for the comparator or counterfactual scenario, they are only a partial evaluation, that is called cost outcome study, but evaluation is partial. But how do we capture benefits and cost in monetary terms? So, in this case, in practice various methods are there to quantify, to capture the health consequences in especially the consequences are captured in monetary terms. Of these, the two most widely used approaches are willingness to pay, WTP, or willingness to accept, that is one, and second one is called valuing productivity gains. We will now start with the WTP, willingness to pay principle. This is in fact based on a certain premise, that is the maximum amount an individual is willing to pay for a given commodity is an indicator of the value to them. So, the extent of sacrifice the individual does is in fact the value or the valuation for the service or the product, especially healthcare service. In the context of healthcare, this involves estimating what an individual is willing to pay for certain benefits, consequently estimating the value of the health benefits of an intervention in monetary terms for that individual. The advantage is that the individual take account of all the attributes of the service of the importance to them and not just the health gains. So, the estimation ways are like stated preference and revealed preference methods. In case of stated one, we use survey questionnaire where responses are taken, where in case of revealed, we are actually going to count the indirect approach, indirectly inferred, or the non-market outcomes. This is observed prices of related market goods. So, valuing productivity gains, which is the next approach. This refers to involvement of placing a monetary value on the estimated productivity, losses associated with a disease that are averted due to a health intervention. Within valuing productivity gains approach, there are various approaches like this involves human capital approach, friction cost approach, and in case of human capital, the potential, all the potential production not performed by a person because of morbidity or early mortality is counted as a production loss. And friction cost is that production losses are limited to the time needed to replace an ill employee. Okay. So, that is basically the evaluation, valuing productivity gains evaluation. So, using these approaches we monetize our benefits that help in carrying out CBA analysis. So, CBA is estimated by basically using formulas such as the cost benefit ratio and net benefit. In cost benefit as a ratio, we usually take for delta C by delta B, And the requirement for beneficial intervention, CB ratio value should be less than 1. So, the CB ratio value which we have already mentioned, that is delta C by delta B. So, and whereas in case of net benefit, which we just simply said B minus C, the net benefit should be greater than 0. So, that is the requirement as a measure of CBA, and CBA is mostly used to make a public decision. So, apart from just cost and benefit, we also have to consider social cost benefit and marginal cost benefit, which we discuss in lectures of week 5 and also in week 7. CBA, please note that CBA decisions are not particular point of decisions. So, to implement a decision, we must take the time component into considerations as well. Now, taking time component into consideration, we can formulate the CBA analysis as follows. So, the net present value is important to mention, that is considering the future value of the benefit as a ratio or divided by the discounted rate, that is R. R is called discount rate, and times its period of the discounting, that means 1 plus R to the power t. So, future value in tth period divided by 1 plus R to the power t is nothing but, and their summation is nothing but called net present value. Let us understand the use of these formula with the help of some appropriate examples. In the example 1, we consider implementing two different preventive measures in a community. Here we say alternative A and alternative B. Alternative A we are considering mass testing, and alternative B is social distancing. Starting with the mass testing, the cost is 1 million, and the benefit, those are like life saved, reduced healthcare cost and economic gains. The total is 1.2 million. Okay. So, so the benefit is higher than that of the cost, whereas in case of for the same COVID-19, we are just the control of COVID-19. We started with its one alternative called mass testing and as called social distancing principle. The cost in case of social distancing is 8 lakh, and the benefit in terms of life saved, then reduce healthcare cost and economic gains, etc. And the benefit, if it is around 8 lakh 50,000. So, in that case our differences are noted. So, to answer the same using different formula, let us get the solution and check which one is better. Now, through net benefit approach, and another one is called cost benefit ratio approach. Okay. So, in case of net benefit approach, alternative A and alternative B, so 1.2 or million as against alternative B is 8.5 lakh. Okay. So, the benefit is here it is actually 2 lakh. So, benefit minus cost, the net benefit is actually 2 lakh on the alternative A, whereas in alternative B the net benefit is actually 50,000. Whereas in the cost benefit ratio approach, we find for the alternative A it is in fact 0.83 and alternative B it is of 0.94. By absolute difference, yes, we have noted, but the reverse is noted in case of cost benefit ratio. The conclusion for the net benefit approach, both alternatives have a positive net benefit. This indicates that they are economically justified. However, alternative A has a higher net benefit and may be more cost effective, and so its net benefit is actually effective. Whereas in case of cost benefit ratio approach, in terms of conclusion, we just find the difference. Alternative B has better cost benefit ratio. I mean B has relatively higher, that is 0.94, cost benefit ratio. Both alternatives have ratio values less than 1, that less than 1 if it is there as per our limit which I have mentioned in the table earlier, that is really justified. However, since the cost is a ratio of to that of benefit, A is lesser cost, that is 0.83, hence alternative A is preferred. So, in both the cases we just see that A is preferred. If the time component is considered, then we have to modify our example as well. So, consider that COVID-19 vaccination program over 3 years, okay. Mass testing and social distancing, now we are including year wise, okay. So, first year, second year and third year. The first year it is the benefit is 4 lakh, cost is 3 lakh, then second year it is 6 lakhs and 4 lakh, and accordingly other years we have mentioned. So, similarly for social distancing also the figures are mentioned before you. Now, we can calculate by their net present value for program A and program B, that is mass testing and social distancing. So, you can just see the by NPV formula, net present value with its future value divided by 1 plus R, with its year, respective year, we will find that the net present value in the first case is as given here, and the second case is here. So, net present value of program A is of rupees 1616,240, okay. So, 16 lakh 0.15, 16 lakh 16,240, and for B it is 13 lakh plus, okay, 13.992 around. So, it is quite sure clearly observed that program 1 has higher net present value. So, even if we have actually counted the year discounting. So, net present value wise we just say in conclusion what we just find that the program with higher NPV is more financially beneficial over the 3-year period. In this case program A, that is mass testing, has a higher NPV as compared to B, program B. This indicates program A is actually financially advantageous. Even though CBA is more widely used, it has both advantages and disadvantages as well. By advantages we have just seen that it is more consistent with how other public interventions are evaluated and facilitate across sectoral basis, and potential to value a wider range of benefits. Monetary output is desirable to a range of stakeholders, whereas disadvantages such as methodological difficulties are attached regarding placing a monetary value on health benefit and between the studies, and also it is difficult to capture non fatal health outcomes, and potential misinterpretations and difficulties regarding the practical interpretations are there. And last one disadvantage of CBA is that equity and distributional concerns are not at all covered. So, after looking at all those 5 methods, the first 3 out of the first 3 we have carefully observed the CBA approach, and the last 2 also discussed. From the 5 types of full economic evaluation we discussed 3, that is CCA and CMA and CBA in detail with examples. The first 2 are least preferred, and whereas the CBA is the most preferred. Okay, that is least preferred means CCA and CMA actually least preferred we already mentioned. Each of these has different ways of estimating policies and interpreting results, and both advantages and disadvantages are part and parcel of these evaluation principles and can be applied in different contexts. So, what we are targeting for the next lecture is the cost effective and cost utility analysis, their features with examples, and the advantages and disadvantages are going to be discussed. And these references are going to be very useful if you are really targeting for higher study and apply for your assignment and calculations in the exam for appearing for the exam. I think you need to go through. With this, I think it's time to close. Any queries, will be welcoming you. for discussion. Thank you.